So what we do, we have a lot of demand for these presentations, but it's hard to find one time that works for all of our members. So we record these presentations and it will be available on the BRA website in about a week. And so if you feel uncomfortable with having your face on our website, you can certainly turn your camera off. Jahan and I love seeing your face. We love interacting with you. You will notice when I'm speaking, oftentimes I'm not looking directly at the camera. It's because I'm looking at the screen to look at your beautiful faces. But anyhow, so you can interact with us through the chat, or you can raise your hand to try to get our attention if you have questions. We encourage you to interact with us. This is an interactive conversation with our guest speaker, Catherine, who Jahan will be telling you a little bit more about. But I did want to alert you to that. And you can see that it says recording up in the top left side of your screen. Breast Cancer Recovery in Action is a Nashville-based nonprofit that provides programs for the breast cancer community. And they include exercise, nutrition, small group discussion, and educational programs. If you're not already a member, we would love to talk to you more about that. And there will be a link to our website in the email you receive after this presentation. So let's see, I think those are our main pieces of information. If you could please mute your microphone while we're talking, that helps avoid background noise. But once again, once it's your turn to ask a question, you can go ahead and unmute. And that is all of our housekeeping. So with that, I am going to turn you over to Jahan.
Thank you. It's so good to see all of you. Happy May, happy summer, if that's already started for you at your house. We're so thrilled today to have Catherine, is it Wall? How do you say your last name?
Wool.
Wool. Okay, Catherine Wool. And we are thrilled to have her join us today. She is a certified genetic counselor with Natera and has a lot of interesting, really insightful information to share about the work that she and her company are doing. We had a chance to meet with Catherine ahead of time and just kind of have a little pre-banter talk. And so we learned a little bit more about her. She is originally from Memphis, but now lives in East Tennessee and Knoxville. I heard somebody say they were in East Tennessee today. I don't know if y'all are y'all affected by the cicadas in East Tennessee the way we are here in Middle Tennessee, because they are dominating my yard. Okay, my dogs are trying to eat them. It's really gross. But in yeah, I mean, it's really bad. I'm like, and the vet said they're pretty bad. They cause GI upset, so I'm not supposed to let them do it, but it's a whole pain. It's a whole thing. Anyway, Catherine lives in Knoxville now, went to UT, and I asked her to share kind of a fun fact about us, or about herself, because I think it just, it helps humanize our speakers and helps us relate to them in a different kind of way than just the cancer connection. And this was her fun fact. She is a Christmas Eve baby. She was born on Christmas Eve. And so she never got a legit birthday, except that she started celebrating half birthdays in June so that she could have like a pool party or something with her friends, I guess, when you were a kid. So I love that you were a Christmas Eve baby.
Now, who do we feel more sorry for? Her mother delivering a baby?
Right. Or Catherine growing up, growing up with a Christmas Eve birthday. And even as an adult, I imagine you still don't get properly celebrated.
No, now I'm a mom now, so I am in the mom situation, but even less so, I'm celebrated.
Even less so, exactly. Well, we are thrilled to have you. Thank you for being with us. And I just wanted to kind of get our conversation started by letting you take the floor and just tell us kind of how you came to be a genetic counselor, and just a little bit about what the training involved and really what you like about the job.
Yeah, of course. Yeah. Thank you guys for having me. As I said, I'm Catherine Wool, born and raised in Memphis, but live here in Knoxville now. So I went to undergrad at UT. I got my major in psychology and biology. I heard about genetic counseling in high school, interested from the start. I knew I wanted to get into healthcare, but not necessarily work directly with patients. Blood and guts kind of freaked me out. So this was kind of a perfect marrying of my interests. So after undergrad, I got a master's in genetic counseling from Long Island University, lived in New York for a couple years while I got my master's there. And then I moved to Memphis, Tennessee after that and worked at the West Clinic, the West Cancer Center in Memphis, saw patients there. I've always, so in genetics, there's sort of different professions, different areas of focus. I've always been very fascinated by cancer genetics. I knew I wanted to help cancer patients. And the beautiful thing about cancer genetics is, you know, it can sometimes give you an answer for why this happened. There's a powerful piece of it that you could prevent cancers from happening in you or family members. So I love working with patients and educating them about this genetic testing offering. It's been a couple years since I've been out of the clinic. I transitioned into industry, what we call it. So I work for the lab now. And in my current role, I talk with medical oncologists, breast surgeons, genetic counselors about our test offerings that include Empower, our hereditary cancer test. I'll stop there and just see if there's any questions right off the bat. I've got some slides prepared, but want to see if there's any burning questions.
Do you work with Dr. Park, Dr. Ben Park?
I don't know that name. My primary territory is Knoxville and about a 2-hour radius. So I'm not familiar with that
Yeah,
person.
he's at
He's
Vanderbilt.
at Vanderbilt.
Okay.
Well, you mentioned, I'm sure you're going to share this, Catherine, but you mentioned Empower. I'm eager to learn a lot more about that specific test. So if nobody has any urgent question, let's just move on to what you can share and people will raise their hand and put it in chat if something comes up.
Perfect. Are you guys able to allow me to share my screen? It says host
No.
has disabled screen sharing.
I think so. How do I do that?
See, go to share screen over here,
Oh, yes.
and then multiple part two. Yeah, there we go.
Okay. Try that.
All
See if
right,
that
here we go.
works.
I think we enabled it.
Yes. Okay, do you see my screen here?
Yeah.
Okay. So just a brief overview about hereditary cancer genetic testing. So as we know, all breast cancer is genetic in nature. The question is, were you born with a predisposition to this? That makes up 5 to 10% of all breast cancers. Sometimes we test family members for genetics and it comes back negative, but there's still an obvious pattern in the family. So we call that familial breast cancer. It could be just shared environments. They have some other genes that maybe haven't been discovered yet, but they are potentially their family members might be at increased risk, even if you come back negative. But the good news is a vast majority of breast cancer is sporadic, just occurs by chance as we age. This just breaks down. So there are a lot of different hereditary cancer syndromes. Primarily today, we'll be talking about breast cancer. So we said 10% of breast cancer is hereditary. If you are found to have a hereditary predisposition to breast cancer, depends on the genes, but it could affect risk of other cancers.
Actually,
Okay, hold on.
I don't think that's what I'm seeing.
I think this.
No.
He's something called David Childs.
No.
Yeah, we're looking at a
Let's see
screen
here.
that's different than what I think
I
you first put
started
up.
to see what you were putting.
There
Okay.
we go. That's
Okay.
Okay.
There we
Okay,
go.
sorry about that.
Yeah.
So depending on the gene you have, will determine which other cancers you might be at risk for, but keeping in mind only 10% of breast cancer is genetic. The reason that it is more likely sporadic, and this kind of walks through of how all cancer is genetic. So typically these genes should be working. They should be preventing your body from developing breast cancer. Over time, one of these genes gets damaged. If that gene then gets damaged a second time as we age, that's when the breast cancer tumor starts to develop. What's different about a hereditary cancer is that there's one damaged gene and one normal gene from the start. So this is how it's hereditary. It's inherited from either mom or dad, can come from either side. So it only takes one other damaged cell or gene in the cell for the tumor to develop. This is why we see younger ages of diagnosis, multiple people in the family, sometimes rarer types of cancer. Red flag. So who should consider genetic testing? Diagnosed under the age of 50 is certainly a red flag. There are national guidelines for who meets criteria. Typically, this is what insurance follows as well. So the number today is 50 and under for breast cancer diagnosis meets criteria. If you've had multiple breast cancers in yourself or in a family member, that is a red flag. Other rare cancers, like if there's ovarian cancer in your family, that automatically qualifies you for criteria as well. And then, of course, if there are multiple family members with the same type of breast cancer or with the same type of cancer, so in this case, breast cancer. This can also be running from dad's side. So as I said, dad can carry these genes. So if dad has sisters or cousins with breast cancer, those meet criteria as well. So reasons to consider genetic testing. As we talked about from the beginning, sometimes it can provide you with an answer of why did I get this so young? You can be proactive and prevent second cancers. So there is an increased risk for additional breast cancers. You can remove your ovaries to prevent that type of cancer, and then being diligent about screening for the other types of cancer. If you are positive, all of your first degree relatives have a 50% chance to be positive as well. So testing those family members becomes pertinent so that they can potentially prevent this. We typically do not test until the age of 18. So there is no association with childhood cancers. Screening for these women doesn't start till 25, even if they are positive. We typically want these women to make this decision themselves, so we wait till they're 18. Of course, there are rare circumstances, but that's generally the rule of thumb for hereditary cancer testing. There are also new therapies being developed just based on these genetics. So sometimes the tumor can, what we call personalized medicine. If you carry one of these genes, there are drugs that specifically target those types of breast cancers. So it can inform even your treatment decisions. And then I talked a lot, there's a lot of misconceptions about men and the breast cancer gene, breast cancer in general. Of course, as we said, breast cancer can run through dad's side. They can carry these genes. There is a potential increased risk for male breast cancer. It's a very small risk, but still a lot more than the general population male. Also an increased risk for prostate cancer and a slight increased risk for pancreatic. What questions can I answer?
Catherine, this is Judy. I believe I read that you all can do testing for reoccurrence.
Yes.
Okay. Can you
Yes,
talk
Judy.
about that?
Yeah, great question. So as Judy mentioned, we do have a totally different separate genetic test that's called Signatera. It creates a signature of your breast cancer tumor that we can detect whether there is tumor in your bloodstream. You can use it after surgery to determine if there's any tumor left. You can use it during treatment to see how the tumor is responding. And then once you're done with all your treatments, it can be ordered every 6 months or every year to see if the cancer is recurring. So that test is called Signatera. It does need to be ordered by an oncologist. Typically, the oncologists are more familiar with it than your surgeon, but you certainly can ask your surgeon about it as well. It does have very good insurance coverage, just like the hereditary genetic testing also.
I asked, hi, this is Herod. I asked my oncologist at Vanderbilt to order a Signatera test for me.
Mhm.
And he said that he could.
Mhm.
He would if I pushed him to do it. But
Okay.
his advice to me, among other oncologists that I am aware of, said that the test is great, but what if you keep on testing positive?
Mhm.
There is nothing they can do for me, and I'm on a recurrence. 8 years on, I'm on a recurrence. So he said, if it came back positive, you're going to possibly have anxiety and think that you're on a number 3 recurrence, and there's nothing we can do at this stage. However, he did say to me that there's a lot of movement in this space, and that he is convinced that this is the way to go in future, and these blood tests will get there in the future, but just to hold off for a while until they're able to be more specific
Mhm.
where it is in the body, so they can
Yeah.
treat it.
Really good points that you bring up. You will find physicians that feel that way. Of course, the anxiety piece will be up to you. So he is correct in the sense that the Signatera test is not in guidelines yet. So a lot of providers don't really know what to do with it. The other thing is, when you test, if and when you were to test positive for a recurrence, the next step would be to order a scan. Most insurances going to want to see the recurrence on a scan. So the anxiety piece comes in that you're mentioning is if you were positive and we don't find it on a scan, there's not anything we can actually do today. What you could do is keep testing. If it keeps increasing, keep ordering scans. He is correct that this is a new technology. It is and will become much more widely available as more data comes out. But as of today, it is able to be ordered. And I have found if you push your doctor, they will do what they can to get you what you want. Is that Dr. Park at Vanderbilt that you're speaking of? Okay.
Yeah, it's
Yeah.
not part of Vanderbilt's
Okay.
standard of care.
Yeah.
So we do have a question in the chat, which is, aside from the BRCA genes, what genes are most typically associated with breast cancer that would be of concern for people in this?
Yeah, great question. So there are primarily 10 breast cancer genes that more or less every lab that you use will test for these genes. These genes they've been narrowed down to the 10 because there is a high risk for a second breast cancer. So many women will get these tested to make surgery decisions.
Right.
If you were positive for one of them, maybe you would change which surgery you would do. So let me pull up what those genes are. Let's see here. I will say that if you have had genetic testing and you only had BRCA 1 and 2 done, you are eligible for more testing. So at Natera, we offer up to 81 genes. So that
Part of the Empower, I think that
Yes.
was actually part of our next question. Like I, for one, was diagnosed with triple negative and we did a stat test,
Yeah.
which looked for BRCA to make decisions about chemo.
Mhm.
And then the question was what to do next, right? To look for lifetime cancer risk.
Yeah. So
Catherine, are you
typically,
saying 81 genes that y'all can screen for are all for breast cancer or just for all types of cancers?
let me show you this real quick.
Okay.
I've got it pulled up now. Okay, do you see my screen of this gene table?
Yes.
Yeah,
Yeah.
it's a little
Okay.
small.
But yeah.
Yeah. And I can email this out to you
there we go.
all. So these are the 81 genes. This usually is the panel that providers will select. There is also a 40 gene panel, but you can see that there are multiple genes for breast cancer. and then other types of cancers as well for ovarian, endometrial, colorectal. So if you've only had BRCA1, I would consider that incomplete testing. I would
Right.
do more. If you've had the 10 stat genes, whether you were tested at Natera or somewhere else, typically those stat genes, it's all 10 of them are the same at each lab.
Yeah.
I still would consider that incomplete, and I would go for either 40 or 81 genes, just to rule everything out.
Right. And so I think on there, it shows that there can be commonalities. So if you come up with a mutation that's common in breast cancer, it can also give you an indication about other types of cancer that you might want
Exactly.
to keep
Yep.
on the barometer, or, pay attention to, right?
Exactly. Yeah. So for example, the BRCA gene here, increased risk for ovarian and endometrial. Some other, like the CHEK2, increased risk for breast cancer, and slightly increased for colorectal.
And the Empower does the 81 genes, is that?
Correct. So we do offer 40 or 81 genes.
Oh, so it can be two versions of it?
Yes, it can be two versions. If you've had 40 and wanted more genes,
Uh-huh.
that is an option as well.
Okay.
Mhm.
And
What's
it's a-
what's the RNA?
Yes, so we do RNA for this as well. So every time you do a genetic test, there are 3 possible test results. One's positive, we found a mutation. We know this is causing hereditary cancer. The other's negative, no mutation found. This is likely sporadic. Or a variant of uncertain significance. So we found a change in the gene, we're not really sure what it means. We use RNA testing to help clarify that VUS status. We treat VUSs like a negative until we know otherwise. Most of them do get downgraded to negative. If they ever get upgraded, your provider and you should be notified.
And these, so Empower tests are generally covered by insurance?
Yes, generally covered by insurance. There is, so I mentioned national guidelines. The national guidelines, I talked through, you have to be under 50 or you have to have multiple breast cancers in the family or someone with ovarian. I will tell you that the Society for Breast Surgeons has opened up access more, and they say that every woman with breast cancer is considered eligible for testing. So because of that, if you want testing and you're being told that you don't meet criteria, keep pushing, or let me know. The providers can still offer this testing. If insurance denies it for Empower, we will not bill the patient.
So is there any difference, I mean, in terms of running it through insurance, what would be a reason not to do the 81 gene versus the 40? Why wouldn't you just jump to the larger panel?
Yeah, I mean, that's me as a genetic counselor. I would want everything that I could. Some providers will do the 40 gene panel, because the more genes you test, the more likely you are to get an uncertain, that VUS, variant of uncertain significance. But as long as you're comfortable treating that like a negative until you know otherwise, and just know that the lab keeps tabs on that. We notify you if it ever gets upgraded or downgraded. That's one reason someone might order 40 genes instead of 81, lower VUS rate.
Okay.
And then in terms of insurance, say you were diagnosed mid-40s and you have a daughter or a son.
Yep.
How do insurance companies look at that and their
Yeah.
risk?
Yeah, great question. So typically, when you do hereditary cancer, you want to test the person in the family that's most likely to be positive. So that would be, I would want to test the patient who had breast cancer at the youngest age or had breast cancer versus testing their daughter who has a family history of it. The reason is we want to find out, is the cancer in your family hereditary? So if I tested your daughter and she was negative, that doesn't tell me what caused the breast cancer in the family. If I test mom and she's positive, we know that there's a BRCA gene in this family. Then I test the daughter and the daughter's negative. She's now back down to general population risk despite all that family history. Everyone is eligible that has a family history of breast cancer for genetic testing, typically testing the person with breast cancer first is the best route.
But did you say earlier that let's see, I jotted it down. If we are positive, our first degree relatives have a 50-50 chance of developing that. Is that what you said?
If you are positive for one of these genes, all of your first degree relatives have a 50% chance to also be positive for that same gene.
I got you. Only if you had a mutation.
Correct.
Okay,
Yeah.
okay. Only if you have, okay, gotcha. Positive for a mutation. I
Right.
gotcha. Okay, I
Because-
misunderstood that.
Having, like in my case, I'll just fill myself out again. My sister and I both had breast cancer. So my remaining two sisters, pretty high chance. But
Yep.
my sister and I both come up negative on the panels we've done.
That's good.
We
That's
still
great
worry
news.
about children.
Yeah,
Right, we have familial risk,
Mhm.
but
correct.
it makes us nervous, right? There's something that has been missed or hasn't come up.
Yeah. So perfect example. So you and your sister are both negative, which
Right.
means the breast, we don't have an answer what's going on. It does mean that you cannot pass this on, right? For the gene, because you can't pass on what you don't have. But it also means that your sisters don't really need testing because there's unexplained familial risk. Just having that risk in their family might put them at eligibility to get breast MRIs earlier or alongside their mammograms.
So then it just impacts, the best route is just to have impact on monitoring.
Yeah. Yes.
Right, okay.
Yeah.
Interesting.
And how often is this a one and done, or how often do you recommend this gene panel be done on patients that have had
Yeah.
cancer?
It typically is a one and done. If you do the 81 genes, unless, we discover something that we've never seen in 20 years, we will continue to try to reclassify any uncertain results, but these genes don't change, right? So when we test you, whatever that the result is at that time is probably not going to change, even if you were to retest. The only reason I would consider retesting is if you've only had a couple genes tested.
But does the panel get expanded? Like, I think when I
Mhm.
had done my testing, they said like maybe every 10 years to
Yeah.
revisit, just in case there are more genes found or
Yeah.
mutations found.
It's certainly a good idea to check in probably every 10 years. So these do update when, we had BRCA testing for a long time, just BRCA. About 10 years after that, we added 40 genes. About 10 years after that, we added these 81 genes. So 81 today for breast cancer is pretty all-encompassing for what we know about BRC, breast cancer genetics. So I check in 10 more years.
And you said the oncologists are typically the ones that write the order for this testing. Could breast surgeons also write it, or is it just the with it, or?
Good question. So I think when I mentioned that, I meant where I was talking more about the Signatera, the breast cancer recurrence test.
Okay.
For Empower or hereditary cancer, you will see more surgeons ordering this. They should be very familiar with this. Typically, they're ordering it prior to surgery. If your breast surgeon for some reason didn't order it, your oncologist, of course, can. There are also genetic counselors available. So I wanted to, can you see my screen here?
Yeah.
National Society of Genetic Counselors. I can send you this link and an email, and you basically can put in how to find a genetic counselor, whether in person or telehealth. I know there's a good number in Nashville and Memphis and Knoxville, where I am too. And then Natera does also offer genetic information sessions. I'll include this link as well. And this is just a phone call, a free phone call you can schedule with any of our genetic counselors to talk through your risk or try to find someone that could order the test for you. These Natera genetic counselors can also talk to you about Signatera, which we talked about.
Right. Yeah, so that was a question, we pop-up genetic testing. So I think locations and, mail order testing, differences in testing brands. So, you know, how do the different, testing brands compare? And,
Yeah.
you know, are there any that you would maybe caution us to avoid?
Yeah.
You know, honestly, every time I log on to, Instagram, because I follow various breast cancer influencers or what have you, I'm like swamped with different, ads for genetic testing and all of the breast cancer things.
Yeah.
So do you have any thoughts on that?
Yeah, of course. So the big labs in hereditary genetic testing that I would recommend to anyone in my family would be Natera, Myriad Genetics, Invitae, Ambry. Those are the big ones. You know, 23andMe technically does testing for this. I would not trust that for medical decisions. It is you have a fun test, but if you're BRCA positive on that and you saw me as a patient, I would retest you at more of a reputable lab. LabCorp and Quest do it as well. There's nothing wrong with that test. I just have more familiarity with labs that specialize more in hereditary cancer testing than doing everything. Outside of those, you know, of course I can answer like one-off questions, but if you get something in the mail asking you about BRCA testing, I wouldn't trust that. These are typically tests that have to be ordered from a provider.
And so like a pop-up testing, do you guys ever do anything like that where you're out and about?
Not really.
Right. And so even if somebody called in to talk to one of your counselors, are you ultimately going to refer back to provider and say, you know,
Yes.
order through your oncologist or your surgeon, whomever?
Yes. Yeah, we can kind of help point you in the right direction. But these do have to be ordered from a provider. Your OBGYN can order it too. They have a little less familiarity than your surgeon or oncologist, but it really it can be any provider. It just can't be a patient order. Yeah.
Your counselor is going to help kind of pull together the information. and
Yes.
say, this is why I think I need it.
Yes.
Ultimately, it's not really an area to cut corners. I mean, this can be life and death, right? This is cancers. We all know the gravity of the situation.
Yeah.
But
Yeah.
but so then okay, so we're talking about a blood test, right?
It can be blood or saliva for hereditary cancer. Yeah.
Okay, I'm just wondering, so two-part question.
Mhm.
What's the length of time before the panel comes back? And then
Yeah.
we meet with a genetic counselor to read the results? Is that how we do it? Because our doctor's not gonna know the results, correct?
So a couple different ways. So first, it takes usually 2 to 4 weeks for
Okay.
results to come back once we get the sample, and that's across any lab typically. The results will go to whomever ordered it. So whether that's your oncologist, surgeon, if you see a genetic counselor that works at the clinic or in your area, basically just that doesn't work at Natera or the lab, they can also order and receive the results. Typically, those providers, they will be the ones to call you to give you the results and talk through it. If at that point you want to talk to a genetic counselor at Natera or just locally in your area, you can take those results to them to talk through it. The results do, if you are positive, it does walk you through what the guidelines say, what you are at risk for, what guidelines recommend for your increased screening. So the results, even if your oncologist is a little unfamiliar, it spells it out for them. But if you feel like your oncologist or surgeon just didn't do the results disclosure justice, I would certainly meet with a genetic counselor.
Great.
That's great.
We've got one
We got a
question in the chat.
from Janine. Go ahead.
I was diagnosed at 48 years old, took a genetic test, which came back negative, had full hysterectomy, but yet to have a colonoscopy. Should I have one first or have one?
Yeah, so given that you were negative, we don't see any increased risk above general population for colon cancer. So the recommendation would be just to get your colonoscopy when your physician recommends, which I believe is 50 today.
They just lowered, I think they just
thought
lowered it to
so.
45, actually.
Yeah, I thought so. So at 48, you should be eligible for a colonoscopy, but just because you had breast cancer and your genetic is negative, there's no increased risk for colon cancer above the general population.
That's very helpful.
That is.
It's complicated. It's like a full-time job trying to keep up with all this, and the recommendations are changing every year.
Yeah. Yeah. I have a question.
Good.
Based on my personal circumstance, I've been told I have had a recurrence,
Mhm.
but Dr. Park is not sure if it was a recurrence or another primary cancer.
Okay.
And I was a little bit shocked, stroke upset with that, because I'm like, oh, well, if he doesn't know, well, what am I doing? So my question to you is, are you guys working on any future tests in this area that can decide whether or not it's a recurrence or another primary cancer?
Mm-hmm. Good question. So a couple thoughts there. One thing you could do is push for the Signatera. If that was negative, it would lean more to that this is a second primary, because Signatera is only designed to one tumor. So he could send off the original biopsy if Signatera is negative. If it's positive, then this is a recurrence. If negative, it could be, so the sensitivity is not 100%. So just because it's negative doesn't mean that it's not there, but it might sway him one way or another. It would basically just give you a little more information. As far as working on a test specifically for that, there's not really one available today that can answer that.
Okay.
All right,
Because,
Melanie.
I don't know what they did with the tumor. The tumor was removed and it went for oncotype, and then I found out that oncotype is not done on a recurrence.
Mm-hmm.
They did it on me anyway, but I did not have access or know at the time of Signatera or Natera or any of your genetic testing.
Yeah, and my colleague in Nashville probably works with Dr. Park. I will certainly get him to talk with Dr. Park soon about Signatera, because I think it could be a good option for you.
Okay.
Thank you.
All right, Melanie.
So we were diagnosed probably over 10 years ago now with BRIP
Okay.
1.
Mhm.
And I was the primary that started the testing, even though my aunt had already had breast cancer twice. My grandmother had had it, all on my father's side. He has the BRIP, and both of my brothers do. We each have a child that's carrying it. So my question is, since it was over 10 years ago, and back then we were told they did next generation sequencing, which was 16 genes. That was
Mhm.
what I was told. So are you saying that we should be tested 40 or 80?
Good question. So the chance that someone carries 2 gene mutations is incredibly low. So most likely, so if you have a positive result from 10 years ago, that is probably explaining the breast cancer in your family. So I wouldn't necessarily say that you need additional testing. We know BRIP1 causes hereditary breast cancer. So I think that if you are positive, that testing is typically sufficient. Now,
Okay, so you're saying these 40 to 80 genes are specifically for breast cancer?
no, they are for other types of hereditary cancer. So if there's any other family history going on in your family, you could consider more testing, which I meant to mention. If your family history ever changes, that is also when you should consider more genetic testing. Now, since you had 16 10 years ago, it is worth revisiting if you wanted to, but most likely the BRIP1 is probably explaining the breast cancer in the family.
Well, in the beginning, they told us it was more like the BRCA one, but now I think it's more like they're Vanderbilt's following both my daughters. One of them's already had a bilateral. She didn't have the gene, but she had cancer cells. She did the bilateral, and she can't have any more children. She didn't remove her ovaries. But my younger one is 30, and they're checking her every 6 months, and she just started with her breast MRIs. But they've told her by 35, she's got to have a hysterectomy. So, is that still valid?
Yes. BRIP1 certainly does slightly increase the risk for ovarian cancer as well. I don't know specifically what age they consider that 35. I would have her double check with her OBGYN and oncologist if it is truly 35.
Well, they're checking her every 6 months. So they keep printing out and telling us that this is standard. So I'm guessing that's still correct.
Yes.
But I was just
the-
asking. Thank
Yeah,
you.
certainly for the breast cancer screening every 6 months with the BRIP positive makes sense.
Okay.
Okay, we have
Alright,
a,
we've got
yeah, we've
a,
got a new question that just
question.
popped in.
I
Okay,
have
let's
one.
see. So Janine, one of our listeners found out 5 years ago that her grandmother had ovarian cancer. And she's wondering, does she need to do more testing now, even though she had a hysterectomy, with knowing her grandmother's ovarian cancer history?
So it would depend on how many genes you were tested for at first. If only 2 to 10 and you were negative on those, I would consider more testing.
And what about for the,
Hey, just a quick little throw in there on that. I've had a complete hysterectomy. They've taken everything, but they make me go every year because they said, like the gene that we carry, BRIP, it does increase the odds of ovarian, even though I don't have ovaries. That if I'm going to have a recurrence, it's going to be in the peritoneal area. So they're still checking me every year. So whoever it is that's had a hysterectomy, that's not a get out of jail card free, is what I'm saying. I thought it was. Well, back when I was 46, so they took everything.
Mhm.
I mean, I told them to take everything. I had children to raise. But what I'm saying is they have told me, in fact, I went through a scare just 4 weeks ago. I had to have a full CT. It was negative, but if I'm going to have a recurrence, this is what they're telling me. Even though I've removed everything, that's probably going to be my prominent area. So whoever it is that's asking about the hysterectomy, it doesn't clear her out, I would say. I would still be getting somebody, they still do pap smears, and I'm 64.
Yeah. All right, I mean, I think that makes sense.
Yeah.
No, I've had a bilateral mastectomy and still checked every time I go in.
Exactly. Yeah.
Constant diligence the rest of our lives, I think. Is
Yeah.
Yeah. Good reminder, Melanie. Thank you.
Yeah.
Yeah.
Well, their point is we have a lot longer time to be looking at a possible recurrence.
Right.
Because
yeah.
being diagnosed in your
40s.
40s and then you think you're going to live to maybe 80, that's 40 more years of a
Right.
possible bump, lump, or something. And just being diligent, I think I've had to caution ladies in the past, don't just think, oh, one and done. I'm clear and I've had my breast cancer and I don't have to worry. Or you do have to be diligent, and you've got to stay. Because I've had 3 different genetic tests because I was tested way back. And then my genetic counselor contacted me and said they've got a more updated test. And that was just within 3 years. And I had to have a second one. Then when my daughter had some cancer cells, I had my next generation, and then they repeated it through Vanderbilt again, just to double check, and it still came out the same way. So I'm saying the first 3 showed nothing. it was the fourth one where we picked up the BRIP.
All right.
Yeah. I was gonna say, I have a quick question, and not to make it too individualized, but just, I had just turned 41 when I was diagnosed with breast cancer, and I have no family history that I know of, but I have a daughter and a sister. So I did get tested for the 2 BRCA gene mutations, but that was it. I've never had any further testing. I'm now 6 years out. I mean, is there any kind of statute of limitations, or I could go in and ask for this panel, even though I'm far removed from treatment now?
Yeah. So the tricky thing is insurance coverage. Typically, if you have the exact same insurance you did 6 years ago, a lot of them have a once in a lifetime policy. Now, if your insurance has changed or you have a different policy, it's worth resubmitting to insurance. The other thing you can do is at Natera, and many other labs do this as well, we will submit for insurance coverage. If they deny, we have a cash price of $249. So if insurance won't cover it, $249 that can be worked out in a payment plan. That's also as high as we can bill. We can use compassionate care program to help get that cost down as well. I think it's worth it as a genetic counselor. If it were my family member, I would help pay for it. So yeah, I would certainly get more genes other than
Which
just
one is
BRCA.
that? Is that for the 81 gene panel, the 249?
If you were going to pay $249, I would get 81 genes, you know? Yeah.
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 Sounds like you're negotiating.
No,
It's-
no, I'm just,
No,
no, I'm sorry, I was just trying to make sure. I was like, but which
The
one?
41
Yeah.
Well, so that leads me into my next question. I was gonna ask you about, what about our uninsured
Yeah.
friends?
Yeah.
Is that, so they would pay a cash price of 249?
No, so typically our uninsured patients follow a different financial assistance. We will cap the price. Typically, it can be as low as $149, $0. It's just if you have insurance and they deny it,
Right.
Okay.
you
So our
might.
members that have no insurance, we should encourage them still to reach out because
Yes.
things can be worked out.
Yeah.
Absolutely. Yeah. There's really good financial assistance for no insurance.
Okay.
For underinsured, we still have very good insurance. Typically, you're not going to pay more than $249, and it's a lot of times is less than that.
That's great.
Yeah.
I think that's a lot less than most people would expect.
Yes.
When you're talking, genetic testing, it sounds so woo-woo.
Yeah.
But yeah.
Yeah.
that's
And
like
typically it's
money,
yeah.
but I would have guessed it would have been a lot more significant.
Yeah, I thought it was
than
gonna be
that.
at least 4 digits.
Yeah.
Yeah, no, and it can be worked out in payment plans. And since there's been a lot of confusion about the panel size, so it's $249 no matter what size panel you get typically. So if it were me paying out of pocket, I would want as many as possible.
Sure. Right.
Can I just ask like a general question?
Of course.
Talking about for people to get cancer, they have one damaged gene and one good gene. What do you think causes that gene to get damaged in the first place?
Yeah. So we don't really know, as you can imagine. And it could be environmental things. Just as we get older, our genes mutate. A lot of the times the mutations are benign, meaning they don't cause cancer. So we just really don't know.
So the type of damage is what causes the mutation? Is that it or?
Yes. So basically it's something, the gene in your body has changed, and that is what is causing the tumor to grow.
Yeah, because I mean, I read all the time that younger and younger women are getting diagnosed with breast cancer. And I know the two of us were both, I was 46, you were younger than me. I see Brittany on here, she was younger. I mean, it's just something is happening that
Yeah.
the ages are going down.
Yeah.
Part of that is better care.
Better, like, yeah,
Screening.
mammogram technology.
Like when I was diagnosed in my 40s, I was considered a zebra.
Yeah.
I'm almost 20 years out, and it was like, oh, and no one, I had to push to get mammograms because my aunt I started mammograms at the age of 35, and I paid out of pocket for years because insurance would not cover. My first 3 genetic tests, I paid out of pocket. my insurance wouldn't cover. And believe me, it was way over 249, way over.
That's where the
Mhm.
numbers come from that we're thinking of. Yeah. No, the world is changing for better, I think.
Yeah.
All right, we do have
Well,
one question in the chat, and then we're going to be wrapping up shortly. We're at 12:54,
Mhm.
and we do need to be respectful of everybody's time. What laws protect our genetic information? This was an issue way back in the day.
Yeah.
And yeah, there's always concerns about like what insurance companies could do if we're found to have a mutation. Could they deny coverage? And there's a lot of serious issues around this, I think.
Yeah, really good question. So there is the GINA, Genetic Information Non-Discrimination Act, that says that your health insurance, your employer cannot discriminate based on your hereditary cancer genetics. This does not apply to life insurance, cancer policies. Typically, you know, those are private entities. Typically, they're asking about a diagnosis of breast cancer anyway. Sometimes if you can tell them my genetics was negative, I am not at an increased risk for second primaries above the general population. Sometimes that's helpful for insurance, for your life insurance to know. But your health insurance and your employer cannot discriminate based on these results.
Okay.
We've got a quick question about somebody that's left Tennessee and moved out of state and has a new insurance. What's the best? Is there a website or what's the best place to go to find a genetic counselor in our area?
Yeah, I'm going to send you guys an email
Yeah,
after
we
this.
can,
We can post
yeah.
that as well.
What we'll do is, when the recording goes up on the, website, we can have a link to the website, with the video. And we can also see, I don't know if there'll be time to get it in the email, the post, Banter email, because it's probably already set up. But we will definitely have a link, on the website.
That has some resources about finding genetic counselors.
Yeah.
Yeah, perfect.
Okay, that'd be great. Any final questions?
Um,
This has been so informative. I have learned a ton. Thank you very much for your time.
And then we did want to introduce next month's
Mhm.
topic. We hope you all will come back to see us, and you're welcome as well, Catherine. Always like to see a friendly face.
Let's see how I can do this.
Yeah, you can do big things.
Can I do the big things?
Yeah. It'll be summer break for us. We're gonna have a bunch of kids running around, so
Yeah.
we're gonna look a little older next month.
Yeah, if you thought we were ragged and strung out today, just wait till next month. Okay,
No,
wait a
this
second.
is not it.
I'm trying to go to the next one. Hold on.
Between us, we'll have 5 kids wearing us out. We'll be Ubering all summer long.
Hold on. I'm gonna find it. Basically what we're do, man.
This is being recorded.
I'm sorry. What I was trying to share is the graphic for next month. It's on June 12th if you want to mark your calendar.
Yes.
It's on June 12th from 12 to 1, and we're going to be having a cardiologist, nurse practitioner. Her name is Amy Irvin. She is here at St. Thomas in Nashville, and she's going to talk to us about cardiac health.
Protecting your heart.
Protecting your
after
cardiac
treatment.
health after treatment. You know, if y'all haven't figured it out already, chemo is one of those things that just keeps on giving. And we have to really look at all the ways it's affecting our bodies. And so we're going to talk about cardiac health. And
so important so many different ways.
Thank you for my check.
If you did infusions or you're taking hormone inhibitors or all the different
there's
reasons.
a lot of different reasons.
And
Yeah.
fortunately, or hopefully we're all aging, and that matters too. The women's cardiac health, very, very important.
We have a lovely graphic. I'm sorry you can't see it, but anyway, it'll be on our socials soon, but it's June 12th. If you want to mark your calendars, we would love to have y'all come back and join us.
Thank you, Catherine.
Thank you. Have a great
Thanks,
afternoon.
guys.
Appreciate
Bye,
you.
ladies.
I love seeing you.
Bye.